think we're going to go ahead and get started. So good afternoon, everyone. Such a pleasure to be with you all today. So thank you very much, Trudy, for inviting me and to inviting me to chair. And I think, what wonderful talks we've had so far this morning. And, we're going to sort of build on that in this session. Quick introduction. So I'm Sally Nicholas. I'm the head of health systems within infectious disease challenge area at the Wellcome Trust. And I will be your chair for this post-lunch session titled Enabling Health Research in Every Healthcare Setting. Like the talks earlier today, we'll have the plenary first, after which we'll have an opportunity to ask questions. And then we'll have a series of consecutive talks. And I'll ask you for those talks to please keep your questions till the end. There's a slight change from the agenda as Shafiq Makumbi and Dr. Nadia Tago unfortunately aren't able to join us today. So the presenters today are going to cover a nice breadth of geographies, but also breadth of topics from building networks for data sharing to capacity building for AMR. But they present, I think, some common themes around the challenges and opportunities that exist in conducting research across various health settings, particularly in resource-poor settings. And hopefully we can dig into that a bit more at the end of the session. So without further ado, I'm going to move on to the plenary session. And I'd like to introduce Dr. Thomas Nyirenda, who will be giving the plenary talk. And his talk is entitled EDCTP, Connecting and Building Research Excellence Across Africa. So over to you.
Thanks, Sally. I can't resist to welcome you again to Cape Town, in this beautiful town. When you're in a rich man's house and guests come in, if you're all taken up by this excitement, you forget it's not your house, and you keep saying, oh yeah, welcome, and say, yeah, but that's not your home. I say, it doesn't matter. So welcome again. And I'm really excited to be here. And I must also say, we should all be excited because it's really exciting to work in Africa. And this continent has a lot to offer. I don't know how many people believe that Africa has a lot to offer in terms of shaping the global health agenda. I don't know. Yeah? Oh, lots of hands. So thank you very much. And so I have a presentation just to show you how EDCTP had the philosophy of putting together networks in Africa and how it fits in the environment. And I think it's also a great lesson to many funders because this is a learning process. I don't think there's any funder in this room that can challenge us that they have done it all and they know how to set up networks and this is how it should be done. We are all learning as we go along. So, as I say, Africa is a great continent. Biggest genetic diversity you can find. Just across the border in Namibia, if you've been there, you find there is Caucasians of German origin, African like me. There is the Bushmen, and there's South Africans, of course, there. And it's very difficult to say that if you do a trial in Namibia, whatever you're going to find is going to be generally applicable to all that live in there. Africa is a great example of One Health, the interaction between environment, people, and animals. I don't think you can get a great example like that. Africa is predominantly the youth. Africa has the biggest burden of diseases, a lot of unresearched populations. I am Malawian, and you can see from that slide, I am 50 years of age. I was born when the under 5 mortality rates were that high. So basically, 2 of my Malawian that I was born with on the same day did not see their 5th birthday. I don't know how I survived. My mother can't remember how many vaccinations I completed. A lot of diversity. I am unresearched. I've never been conscripted in a trial, but I think I'm an eligible candidate for so many things. And so are a lot of things. I was looking at Pontiano and think, I want to ask him the same question. Do you know that you're probably not fully vaccinated? but I'll ask him at dinner today. Okay. But to say that around all these advantages and opportunities, we don't have problems, is deceiving ourselves. I don't know how well you can see this slide from WHO, but our countries have the least number of full-time researchers per million population. Most of our countries have 7 people. The rest of us are just part-time researchers. While in the West, 300, 400, 500 per million population. That's a big challenge. Africa is still affected by what some people call the evils of the past. We are divided through African languages that are foreign origin. Those who speak French want to work with the French-speaking one, and those who speak English wants to work with English-speaking people, because that's the way resources flow. There's nothing wrong with that, but the resources have that bias, and people align themselves to where they can find the resources. This is also something that is very pertinent in Africa when it comes to epidemics. Most of us can't move freely between our own countries just because we belong to a certain block of countries or alignment. I was once threatened with arrest in one African country because the immigration officer said I didn't have a transit visa. And there goes my colleague who is Danish working in EDCTP, and they stamp his passport. They say he can go, he's free. But we have to question him. Sit down here. So I said, hey, Ula, can you come and negotiate with this man? So I was at the mercy of a European colleague to bail me out in an African country. So this is where we are. And then, as if that is not enough, the corruption suspicion index is daunting. All the countries you see there, including mine, are in red. Anybody from South America? Anybody from India or Asian? Thank you very much. So you can see we are not actually the same. Welcome to Africa. We are equally corrupt. That's why you should come to this conference. Thanks, Trudy. So within these challenges and opportunities, I must say that what I've just said to you now are not really challenges. These are what makes our job interesting. And in Africa, we are used to achieving great things by succumbing great adversities. As I said, I come from Malawi. Every tourist who goes to Malawi, they come back and say, why are Malawian people always smiling, but they're living in dire poverty? So we are not poor, we are happy, So that is what we are. So amidst that, when EDCTP was formed some 18 years ago, was the question, how do we link Africans and African research institutions so that they can work together with all these challenges that I've mentioned to you and opportunities? So we did something that was unusual. We put out a call for African institutes to come to South Africa. And when they arrived in the room, we just asked which region they come from. And those who said West Africa, we said, that's your room, you go in there. East Africans go in that room, and West Central Africans go in that room, etc. And then we locked the doors and gave them the agenda. And the agenda was, you discuss what your regional problems are and come up with regional plans on how you can build research capacity in your regions and build trust that has been eroded out of you by the evils of the past. They discussed, there were losers and winners, because some people walked out the room and said, I'm not ready to have this discussion. But those that were ready, they wrote very nice proposals. And that was the birth of the regional networks of excellence. This is something that Trudy and I had talked about 18 years ago when we met under a mango tree and say, is this possible that you can force cooperation among Africans? But it did happen. And here we are, we have now 4 regional networks of excellence, and we have gone through a long period of support, which I will not go in much into detail, but between 2008 and 2020, we have had 3 rounds of funding of those networks. We started with 10 million, raised that to 12 million. Why? Because there was a need to include neglected infectious diseases, which were left out. Then they got 18 million and asked to increase their outreach to other countries beyond the original networks. And then the UK gave us money just last year to give to the networks to launch fellowships, PhD fellowships, specifically attracting only female candidates, a very sexist call, but addressing a very important subject of gender disparity in science. And here comes my message to those of you who come from funding agencies or you have friends in funding agencies like Sally. This is a long-term business. And I think the practice of funding networks to have only cycles of 3 years, then you kill it, you start another network, then you fund it for 5 years, then you kill it, is very unscientific. COVID couldn't have taught us enough. I think we need to start thinking about building things for long term and putting in people who can build careers on the issue, not employing people that are already tired like me. I'm not going to add value, but putting young people who should build careers as part of the, a network. And I think this is where the world can benefit from this kind of initiatives. So that's just a picture of what the networks were in phase 1. And then they increased their outreach, as I mentioned. And in this slide, you can see some of the outputs in the last 7 years, which are quite impressive. A lot of workshops, publications that you can find on PubMed Central Europe, and a lot of trainees. But what is also very impressive is the collaborations I've built. The Global Trials Network is a trusted partner in these networks. And other networks that EDCTP has funded, like those of preparedness against epidemics, like Pandora, IDNate, or Alert, they are part and parcel of these networks. So what we see is that on top of what is already ongoing, you keep adding layers of networks. And I think this brings another challenge. The challenge is how then you network networks of networks. I think this is where we should be taking the debate, because there's no point having too many networks that are, some of which are not talking to each other and a lot of layers, one on top of the other, but we should be saying, how do we coordinate them? And thanks to WHO for the World Health Assembly Resolution 75.8, which John Reader knows very well, and if you have any questions about that, it's a person you can ask. The member states are asking us to have better coordination mechanism of clinical research in the world, thanks to COVID. And I think when we reach that stage, then we can say we are one and start to comfortably use the buzzword, which I even heard last night at dinner, calling us the ecosystem. Yeah, so we are the ecosystem, pieces of the ecosystem. So I think, let me stop there because you will hear most interesting and most valuable presentations after me, just to emphasize the importance of sticking around and working in Africa to make a difference. And this is what I think we should all be looking for. Thank you very much.
So thank you very much for that, Tom. Finished with 2 minutes to spare. I think I asked you to stand because I think you can hear the questions better when you're up there versus sitting. So yeah, open to you guys for any questions for Tom. And I would just say, can you please try to keep your questions short? And if you can, when you get the microphone, if you can sort of walk up closer to the front of the room to ask a question so we can hear up here, that would be very much appreciated. So any questions? So I think we have one over there.
Thank you, Thomas. It was really very interesting talk. Why did EDCTP change its philosophy? Leaving out clinical trials and focusing on other areas of research. I'm just wondering whether the same name could remain if it doesn't deal with clinical trials. Thank you.
Okay, thanks very much for that question. So EDCTP did not leave the clinical trial side and start concentrating on building networks. I was only requested to present the network side of it. But the philosophy of building capacity and networking using hands-on clinical trial work is still the center of the program. I'm sorry if that didn't come out very clearly. Thank you.
Question over there.
Sorry if I missed it, but I didn't hear anything about EDCTP 3 and what the plans are. And I just thought the group maybe should know whatever you can say about where we are with that.
Yeah, thanks very much. So that's a good question. EDCTP has indeed gone into EDCTP 3, and this is a program that was launched in May in France, who are the president of the European Union currently. And that's another 1.6 billion euro program that is supposed to take us all the way to 2031. If you look at the business plan and the strategic research agenda of EDCTP3, nothing much has really changed except the emphasis of epidemics, reimaging and emerging diseases comes in, and these are the areas that we did not do well in EDCTP1 and EDCTP2. There are other changes in terms of governance and areas of participation. And I think one of the frustrating one that probably you may want me to mention is project leadership. In that most African countries that don't have the science and technology agreement with the EU are not at the moment or cannot be project leaders in the coordination or in the network. And that's just the legality of it. And I think there's a lot of people who are working on it now to make sure that that is well translated, and if there are ways to go around it, we can go around them. But in general, all the African countries that are members of the association, their institutes can still get grants. The leadership is a different thing, which of course to us is an important issue, that an African institute leads a consortium because it's part of capacity development and knowing how to run consortia that we want to inculcate in our continent. But that's just a technicality. I'm sure it will be sorted out very soon that we all move forward happily. I hope I answered your question.
Oh. Question back there. Oh. So we'll have the one in the back first and then over here.
Thank you for your presentation. My name is Mercury Shitinda. I wanted to find out, you have mentioned that one of the challenges you're having about networks is them coming to an end or a close. What are some of the things or strategies in place that EDCTP intends on like doing, so that we do not have the closure or ending of networks to start others, and building sustainability? Thank you.
No, thanks very much for that question. I think the first thing, as I said, is advocacy and education among funders. I firmly believe that funders have got a lot to learn from the challenges and mistakes they have made in the past. And if they all remain open to that, we can then address your issue. I was saying that because I am also trained in so many networks in the past, and that is not really just comfortable, that you jump from one research network to another following your tutor or mentor. It just doesn't build any capacity that can be long lasting. But hopefully, this is something that we can all sort out at the funders level as some concern that is, generally understood, that we are going backwards if we do so.
So we're co-chairing on my my part because we're already over, but sort of one more question.
Thank you very much. I am Gustavo. I'm from Brazil. And I would like to ask you very shortly. So during 2000s, we have a lot of South-South cooperation, especially among African countries. So, but suddenly it's over. How you can see how you can be reconnected in a South-South cooperation to improve equity in Africa and also Latin America in your network?
No, so that's $1 million question. And I think, again, if we come back to the table and open up these questions to different players as our general concerns, I'm sure we can find solutions together. I asked the same question because when we talk about South-South networking only in Africa, that's in a complete picture. We should be talking about, South America, Africa, and Asia as, one network. And I think from the funders' side, we should wait to see who is willing among the funders to do this experiment and see how it works, so they can teach others how to do these things better. It's an issue of resources, and as I said in that map, that cannot be underplayed. We come from different delineation of mind, and we are aligned to several different kind of people depending on our background. Those are the things to deal with, even at the funders level, because they are also humans. So for me, the issue of coordination is important. If we have a coordination mechanism, and that coordination mechanism takes up your issue, discuss, and we partner out solutions, and we ask those who have resources to put those resources into it, that would be great. Maybe you should talk to Mr. Bill Gates. Maybe this is an area he would be interested to listen to as well.
Well, thank you. Thank you so much for that, Tom. So we're going to move on now. So right now we have Professor Karen Barnes, who actually hasn't come too far today. She's a clinical pharmacologist based in the University of Cape Town, and she's going to talk about the worldwide anti-malarial resistant network. Over to you.
Thank you so much to everyone for this opportunity, and it's lovely to be able to say welcome to my home, and lovely to see so many people here. So today I'm going to tackle the somewhat uncomfortable discussion around data sharing. I think it's something that has incredible potential for public good, but it often makes people feel wary, feel uncomfortable. And I'd like to try and discuss how we collectively can level the playing fields. Next slide. I've got the machine. Yes. So I'm going to look at this from the perspective of the Infectious Diseases Data Observatory that some of you, hopefully most of you, might have heard of, which aims to strengthen the generation of evidence through equitable data use. And it's been really successful. It's got over 2,000 research contributors, more than 1 million patient infections. It works on 16 research themes, more on the pipeline. And it's a very international program across Africa, Asia, Europe, and Latin America. I'm going to focus on the Worldwide Anti-Malarial Resistance Network, the malaria part of EDO, mostly because it is the mother of the rest of EDO. And WARN gave birth to all of these new platforms for different neglected, poverty-related infectious diseases. EDO was created because of pressure from research communities saying, you guys are doing great things for malaria, but we need it even more for soil-transmitted helminths or schistosomiasis. And so those communities got together and helped us create platforms for each additional disease. The latest request we've had is to look into scoping TB meningitis, and the doors are always open. This achieves economies of scale and the potential for impact. Also keeps us out of mischief. I think in many ways, WARN can be seen as the pioneer of data sharing. It was started in 2009, a time long before funders and publishers insisted that we have ticked the box that our data is available. So there was no stick to make people want to share their data. We had to find ways to encourage them. And we had to give a lot of thought about how will it work best? How will it achieve the goals of data sharing? How does it achieve that public health good? Groups within WARN and EDO have published really good papers outlining their thoughts. We've debated the issues of ownership. And the most important thing about ownership is when data is shared, you're not giving anything away. You're just sharing it. Other people can use it, but you maintain ownership. You maintain control. There is more and more regulation around compliance. I find it overwhelming how many rules and regulations there are around having someone else's data. The latest is the EU's GDPR requirements. And I sat back initially thinking, no problem, I'm from Africa. I don't have to worry about these EU regulations. But then it turns out if you want any funding from EU, or even if you don't want their funding, you just want to work with someone from the EU, you have to meet their requirements. So to have a platform that does that for you is really great. A lot of our governance has been developed together with TDR. And we're really, really lucky that our data access committee is chaired by TDR. And I think that those interactions over the years helped feed into the WHO's policy and guidelines about data sharing, because we've all built up that experience together over almost 15 years. There are obstacles to data sharing, of course. I think all of us have wondered about, do we want to share our data? Is our data up to public scrutiny from international people that are much better resourced than I am? Can I even find my data? This student has left. I thought it was the final database, but it's got an error. It's not easy. And the longer ago the study was, the harder it is to find the data, and the laptop was stolen. And so it is not easy. And then I think most importantly, people are reluctant because they wonder, well, who will benefit from me going to the trouble of sharing data, the time it will take me to share my data? And there's this sense that someone else out there, bigger, more powerful, will benefit. And it's up to us to be able to benefit. And we share data in a way that is equitable. So WARN and EDO have over the many years developed ways to try and address these obstacles. We've developed tools and resources that help people feel more confident of the quality of their data. And for me, it's also way more efficient. I wish someone else had perfected a CRF or a SOP, all the things that I find very tedious, before I started the study, and I could just tweak it for my study. So having other people's tools to help you with each stage of your study improves the quality of your study, but it also expedites research. Data curation is an enormous headache for all of us. And WARN and EDO accept data in whatever format you've got it. If it's an Excel spreadsheet, if it's a very fancy database from a CRO, happy to accept it as it is. And the platform then standardizes the data across wherever people contribute data from and produces data that is compatible. You can download your own data that's now been nicely tidied up by someone else, and you can pull data across all the studies you've done in the last 15 years. And someone else with data access can do the same. So for me, it's a critical point. Curate the data so it's ready for reuse. And we've seen that that increases the frequency with which data sets get reused. So far, we've got some data sets reused up to 15 times. We create study groups, so we get everyone who has relevant data invited to participate in the analysis of the shared data. And then we do individual patient data meta-analyses where you get much greater statistical power because you've got many more patients. You've got increased validity and importantly, generalizability. We don't need solutions for this little corner of Cape Town. We need solutions for across Africa, for across the world. And we've also been able to identify vulnerable populations that are usually excluded from studies. But when you put all these studies together, you get enough data and you understand what, for instance, malnourished children experience. Lastly, we're part of, like many of you, programs to build capacity. Study groups are a great way of developing capacity. I was so excited to sit at a table with the great minds in my field and hear their insights on how we could set the statistical analysis plan better. We do training workshops, we have postgrad students, we have TDR fellows, and that builds deeper capacity. So this summarizes what I think is the most important part of data sharing. Is that once you've expedited data sharing, reuse-ready data, you can synthesize that evidence and answer questions that can't be answered in a single study. For instance, the most recent analysis we did was on the safety of artemisinin combinations in the first trimester of pregnancy. Pregnant women are being treated with quinine, and we know that artemisinin combinations are 6 times more effective, but the WHO was still recommending quinine because they didn't have evidence of safety. So that was a good example. My time's up. Quickly, conclusions. I hope I've persuaded you that equitable, impactful data sharing requires more than just a tick box from funders and publishers and a fair data repository. We need to access the resources that make data sharing and secondary analyses possible. Ensure sustainability. And I like the way Tom says long-term sustainability of these platforms and give better recognition to researchers for sharing their data. And I think low-income country institutions are particularly bad at valuing that data sharing. Thank you to all.
Thank you, Karen. Next up, we have Dr. Jose Gutierrez, who currently conducts research at the Universidad of Valle in Colombia, and he's going to talk to us about neuroviruses emerging in the Americas network. Over to you, Jose.
Thank you very much for everyone to coming and to the Global Health Network for inviting me and my group from Colombia. I have no conflict of interest to be disclosed. I will be talking about our network, the neuroviruses emerging in the Americas network. And our principal interest is acute neuroinflammatory disorders and the healthcare settings in Colombia. So, the network was created in 2016 after the Zika outbreak that happened between 2015 and 2016, and the increase of the Guillain-Barré cases that happened in Colombia and various parts of Latin America. The network is led between the Johns Hopkins University in Baltimore and the University of Valle in Cali, Colombia. It was created as a bidirectional study. We do retrospective and active, which we call prospective inclusion of patients. And initially was a case control study and later a meta cohort study. And its principal objective was to be an observatory of the role of viral infections and acute inflammatory disorders. So, the most important part about the network is the work that we do between all the neurologists, general practitioners, epidemiologists, virologists, and all the multidisciplinary team that works in the network. It extends between 7 cities and 11 hospitals. And the most important part of the network is the training and the coordination and supervision that we do as a team. All the doctors that, all the participants of the network that are trained and in good clinical practices, and we do bi-weekly and monthly meetings to supervise and coordinate and assess problems that we have in a case-by-case basis as a team. The diseases that we our objective are the Guillain-Barré syndrome, encephalitis, myelitis, meningitis, optic neuritis, and cranial nerve palsies. As I told you before, it initially was a case control study from 2016 to 2020 when it became a cohort study. Before the study begins, it needs to be approved by institutional review boards from the university and every healthcare center when it's carried. And they led to the creation of standard operative procedures for fieldwork, and training was done to every general practitioner that is in every hospital, including cases. So we do an inclusion of the cases and we follow up weekly for about 4 weeks. And the patient information is kept online in a platform that is called Wellcome. Also, we take biological specimens from every patient and we send them from all of the 7 cities to the laboratory in Cali, where they are processed. So the process that we do when we have a case, we have a general practitioner that we call a sentinel that is in active search of patients in the emergency department, the UCIs, and general hospitalization floors. And when we identify a case, it is included. We make a consent and if the patient is under 18 and over 7 years, we also make an assent that he has to be agreed to participate in the study. Then we proceed to take data from the patient. We take demographic data, age, where he lives, in which condition does he live. If he's Colombia, we have a stratum from 1 to 6. The 1 is the poorest and 6 is the wealthiest. So we take that into account when we include every patient. And we also take account of the general symptoms and neuro symptoms that the patient has taken, the past medical history, and we do a full neuro examination. And we also see the laboratory imaging and electrophysiological studies that the patient took in the hospital. Then with a specimen collection with the blood samples, urine samples, saliva, and spinal fluid when available. And from 2020, because of the COVID pandemic, we also take nasopharyngeal and oropharyngeal swabs. Then all the samples are sent to Cali when they are processed for PCR and antibodies studies. And we do a follow-up weekly for 4 weeks when they take neuro exam weekly and blood and urine samples every week also. So in the presentation of the cases, we have a lot of challenges that come from the patient that when the sickness starts and to the final stages of the outpatient follow-up. First is the community. Many patients don't consult because they think that the symptoms are a result of curses, witchcraft, poisoning. So that the patient identifies its symptoms and he consults to the hospital is very important part of the identification of case. Then the patient can go to a hospital of the network or what we call a primary care hospital, where it's referred to a hospital of the network when they identify the case and include it. And then after the patient is discharged from the hospital, we have to follow him, but it presents a lot of challenges because the patient may live 8 hours from the city or may live in an island. So that is a thing that we're working in with telemedicine to make the follow-up of the patients. So this is what I call the technical achievements that we as a network have accomplished. We have collected the clinical and biological information from 914 patients, a biobank of specimens that blood, saliva, spinal fluid, a bank of MRIs and EMGs that we can use to further investigate these diseases. And the most important part, and strengthening of institutional research work. And we are also doing from this year monthly lectures on neuroinflammatory diseases from experts. And it also has led to the creation of rehabilitation app that we call Rehab for Guillain-Barré patients. It's free. It's in Spanish and English if you can, if you want to download it. So as a conclusion, networking with different areas of expertise and different research sites led to the strengthening of the technical capacity of work team and general community. This has led to an improvement in clinical and laboratory training. A lot of our physicians have done international experiences in the Baltimore hospital, and training and application of good clinical practices is our flag here. Oh, my time is up, so I just want to present you the network. The two photos on the left are from 2019 when I wasn't part of it. They stopped doing presidential network because of COVID, and just have this photo on the right with two other sentinels in a neuro congress that happened this year in Cali. So thank you very much to all, and to all the centers that are part of the network.
Perfect. Thank you so much, Jose. So staying on South America, next up we have Dr. Jackeline, who's a parasitologist working in the clinical lab at the main public health hospital in Honduras. Today, Dr. Alga is going to talk to us about pregnancy care as an opportunity for a sustainable population-based surveillance system. So over to you, Jackeline.
Thank you, Sally. As many of you may already know, the epidemiologic surveillance systems provide valid, reliable, and timely information. And of course, active surveillance complements routine passive surveillance. However, having an effective active surveillance system presents many challenges. It requires certain level of organization, logistics, and infrastructure, and this means time, cost, and other resources. And also added difficulty when this is in a resource-constrained setting, and when there is a pandemic or an epidemic times, also more obstacles. I am going, for that reason, we are promoting prenatal and delivery care because it offers a unique opportunity to collect population-based data. Specifically, delivery care provides these umbilical cord blood samples that through a non-invasive procedure, and also it allows to measure maternal antibodies in cord blood. I am going to share the experience in building research capabilities in Honduras during the Zika epidemic in 2016. As you may recall, the Zika epidemic was a rapid spreading epidemic. It presented difficulties in measuring the exposure. It presented many diagnostic challenges and many unknowns. All of these were obstacles for timely protocol preparation and IRB approval. And also, of course, it required resources. And when the COVID-19 pandemic appeared in 2020, this added an additional degree of difficulties for sustainability. But we were able to assemble a Zika infection in pregnant women in Honduras disease study. As you can see in the graph, we were able to start enrolling participants during the peak of the transmission in Tegucigalpa, the capital city. And we were able to answer our research questions. From July to December 2016, we were able to recruit 667 pregnant women, and we were able to identify 7 pregnancies to provide the prevalence of Zika in pregnant women of 2%. You can see where the pluses are in the graph, and we were also able to identify microcephaly in infants. And in the graph, the 2 cases that are in the square box were 2 children with severe microcephaly. We were also able to assess neurodevelopment, and we assessed 152 normocephalic children, and we are now in the process of analysis, analyzing exposed and non-exposed children to Zika during the pregnancy. Then we are currently enrolling. We are close by October 2022. We are close to 5,000 enrolled pregnant women. We are taking a blood sample at first prenatal visit. That means that we use a very simple approach. And we are now having a follow-up rate at birth of 94%. Then what happened? Why we were able to assemble in a timely manner of this cohort study? Well, because we were already had a 10-year experience during 2005-2016. We had a congenital Chagas disease study. During that study, we were able to build trust, to increasing our capabilities for data collection and sample storage and collection and storage. Then when the Zika epidemic arrived, we were timely able to integrate the interdisciplinary, interinstitutional, and international collaboration. We strengthen our diagnostic capabilities, and we did on-site and international training. We put together a manual of standard operative procedures and guidelines, and we did the digital training with REDCap and training on a scale for neurodevelopment assessment. Then what happened with the COVID-19 pandemic? Well, we had to move to a low intensity modality, and we were able to answer some questions during the pandemic, like we used pre-pandemic samples to test the specificity of rapid diagnostic tests in COVID. And we moved from Zika to 0 infection in pregnant women in Honduras. And in regard to some relevant activities or highlights, I can tell you that it was a challenge, but then we obtained IRB approvals, national and international. We also were able to publish the protocol in 2016, and in 2020, we published our main paper with the microcephaly outcomes. We facilitated broad participation in authorship in the papers, including local research team. And also we were able to sustain our cohort because of its potential to provide information on neonatal outcomes and or diagnostic challenge other than Zika, including syphilis. We are analyzing some of these we already implemented, but we are analyzing syphilis, American trypanosomiasis, dengue, chikungunya, and COVID. And in that graph, you can see the different cohorts, including in the Zika individual participant data consortium, and you can see the Honduras cohort stands because it started on the peak of the transmission of Zika. You can see that we had an adequate sample size, and also we were able to maintain it on time. A big recognition to the research team and the research institutions in Honduras and international collaborators. Thank you.
Thank you so much, Jackeline. So our final talk is from Walter Agingu, who's currently a lab manager in the Nyanza Reproductive Health Society in Kenya. His main research area focuses reproductive health, and today he's going to talk about the capacity of labs as surveillance sites for N-gonorrhea culture and AMR. Over to you, Walter.
Ladies and gentlemen, my name is Walter Agingu, and I'm presenting a paper on capacity of laboratories as surveillance sites for Neisseria gonorrhea diagnosis in Kenya. So it is known that Neisseria gonorrhea infection is of major public health importance because of three issues. We have frequency, the whole world, and it causes a lot of morbidity, which some of them have devastating outcomes, and it is treatable. Those are the three factors that make it to be important in public health. In Kenya, the infection is treated using syndromic management approach. This is a clinical practice that employs two classes of antibiotics administered to symptomatic patients. The practice is threatened by the emergence of multi-drug resistant Neisseria gonorrhea strains that resist both the drugs used for syndromic management. And you know, we don't have any other option. We use syndromic management specifically. A brief history of antimicrobial resistance originates, we can trace it back to around 1930 when antibiotics were discovered for treating Neisseria gonorrhea. And ever since that time, we have had around 4 changes in classes. And this follows the WHO recommendation where we are expected to change drugs when they show increase in resistance of 5%. So you can see how fast we change. So we need intervention to stop community spread of this multi-drug resistant Neisseria gonorrhea strain. We need it because if we don't do anything, very soon we are going to lose over 10 million people annually, and our gross domestic product, the worldwide, can reduce by 3% if we don't do anything by 2050. So we have to look for interventions, and one of the interventions we propose in this study is surveillance. We feel if we do surveillance, proper surveillance, we could overcome. Now, surveillance is where we target asymptomatic people, and then we screen them, then we can take action to break the spread of this disease. Where is it? Okay. The problem we have in Kenya is that we don't have data that shows the capacity of laboratories as surveillance sites. And that's why we are doing the study. It was just to check if we could have some capacity so that we could be able to move forward with surveillance. In this study, cross-sectional data were collected from 12 public hospitals, and we classified those public hospitals into Kenya Essential Package of Health, and we targeted level 4 and above. That's how we classify hospitals in Kenya. Now, our target population was 25 hospitals, but we randomly selected 12, which was accounting to 48%. We were looking at the hospitals with STI services and with labs that could offer basic microbiology, and those ones with data management system. So in the labs, we looked for availability of basic equipment and consumables that were able to enable us, diagnose Neisseria gonorrhea. I don't know whether the results are visible, but in the results, we found that 50% of the facilities had less than 6 essential equipment for diagnosing gonorrhea, and 91.7% of the facilities lacked basic equipment like biological wire loop for scientists who are here, you understand, and magnetic stirrer. We also categorized the hospitals into urban and rural, and we realized that urban hospitals had only 36.4% of the essential equipment compared to rural hospitals at 18.2%. So when we looked at the consumables, we found that all the study sites lacked 56.3% of the essential consumables. And you can see the consumables here. Those ones were the essential consumables we were assessing. And then when we went to capacity, we realized over 91.7% of the study sites lacked capacity to perform Neisseria gonorrhea culture and susceptibility testing. So in the discussion, we realized that all the 12 facilities reported having qualified laboratory staff, so qualification was not a problem. But also we realized that only level 5 hospital, the only one in the county, had some capacity to perform culture and antimicrobial susceptibility testing, which we usually call phenotyping. But they could not do antimicrobial resistance testing called genotyping because they lacked some facilities. Also, the only hospital had that capacity, but it could only do other microorganisms, other bacteria. It could culture for other bacteria other than Neisseria gonorrhea. So even that hospital could not culture for Neisseria gonorrhea. So this study concludes that the results can enable the government to identify the hospital they can enhance to act as surveillance sites in Kenya. Then we had some few recommendations. One, this lab staff should still undergo mandatory and regular continuous professional development, especially in the field of surveillance. And we also thought that at least one level 5 hospital per county should be enhanced to act as sentinel surveillance sites for Neisseria gonorrhea and other organisms. And then level 4s, some of them should be identified and act as satellite sites where we could collect samples. And then we suggest that ongoing surveillance is required to reveal community transmission patterns of multi-drug resistant strains. Then I would like to acknowledge the sponsors, specifically the Global Health Network. Then I'm going to also acknowledge my supervisors. This is part of my one of the specific objectives for my PhD, which is almost going through. I'm thanking managers and staff of the various hospitals, the universities, and then Nyanza Reproductive Health Society, where I work for. And all of you, thank you. These are my references.
So thank you so much for that, Walter. So I think you can probably would all agree with me that the variety of talks we've seen today have certainly lived up to the title of research in every healthcare setting. I think we've seen the creation of networks to assist with data sharing in malaria and to catalyze lab collaborations in neuroinflammatory disorders. We've seen a focus on surveillance, the opportunity presented by pregnancy to capture data over time, and the need for robust AMR surveillance to guide appropriate antibiotic treatment. For me, in particular, it was really great to see that all the presentations today showed research driven by in-country needs, the outputs of which are directly relevant to the countries themselves. I think this is so important when we think about sustainability of funding, of capability, and also of adoption of outputs into practice. For me, I think there were sort of a few sort of key takeaways. And at the end, I'll give you guys all a chance to sort of say what your key takeaways were from your presentations. But the three key takeaways for me were, one, that networks come in all shapes and sizes. But regardless of the size, there's obviously, the whole is greater than the sum of the parts, and there's a unique value in working within the context of a network, which I think I'm probably preaching to the choir, seeing as the title of the conference is the Global Health Network. The second point, I think, is really about taking advantage of frameworks that already exist. So for example, leveraging existing ongoing touch points with healthcare professionals as part of a surveillance system. And the third really was, there's clearly a role in utilizing research to understand the gaps that might exist in country and the importance of capability building, but in a sustainable way, whether it's looking at things like tools for data collection or for AMR. So with that, hopefully I did a just summary of what you guys presented. And I'll hand over to the audience for any questions you might have. And just to sort of remind everyone to please keep your questions short. Thank you. So I think we have a question over there. We're here first and then down to the back.
Hi. Thanks very much. My name's Emma Kolk. I'm in the School of Public Health at the University of Cape Town. I want to address my question to the data sharing and just to ask how you reconcile a commitment to the principles of open data and data sharing with the need to respect confidentiality and to comply with the various legal and ethical infrastructures. And this refers specifically to routine operational data, which was mentioned a bit earlier, where participants haven't consented directly to the use of their data and certainly haven't consented to sharing their data across borders. Thanks.
Thanks, Emma. Great question. And of course, a big topic. I think that within the Infectious Diseases Data Observatory, all data is fully anonymized and it is shared with the data contributor being responsible for making sure that they're not sharing data that would not comply with existing rules and regulations. And the anonymity is obviously a really important part. Within our tools and resources, we help people with things like, as does TGHN, consent forms that allows for future use of relevant data. I'm very interested at the moment in dealing with artemisinin resistance in Africa and wanting, and it's really interesting to hear about strengthening surveillance data. And of course, that becomes more complex when people get dry blood spots, which we can use to track surveillance. And I think it depends very much then whether it's under the mandate of the Ministry of Health, the National Malaria Program that needs that data rather than a research question. And I think that changes the nature of the consent. Great question, Emma. Thank you.
You get a question right here.
Thank you. My question is also to Professor Karen Barnes. And, thank you for excellent presentation. I was just wondering how you reconcile with validity and precision issues. When you're bringing so many data together, you are increasing your precision, you're increasing your statistical power, you can do meta-analysis. But what about validity, So could it be like that if the quality is not maintained properly, then we'll have very highly precise but invalid inferences coming from there? So what sort of guarding mechanism do you imply for that? Thank you.
Thank you. Another great question. It's a really important consideration when you pool available data. And there are numerous statistical techniques that get used to make sure that we haven't got one study that's an outlier, an influential study. So we do things like adjust for clustering that would occur, not just by study, but also by study site, particularly for patient reported outcomes, how we ask those questions change the answers. So you do see variation. And so it's largely through the techniques used. I also find it really, really powerful to include data contributors in study groups because they have the insights, and when their data seems to be slightly different, they have the position there to say, well, this is what's unusual about our community. It's not that the data is invalid, but there's lots of illicit drug sales of very poor quality drugs or something that would explain that. So I think there are numerous steps you have to take. But we see the value of individual patient data over aggregated data that a lot of other groups compare because we're able to identify the subpopulations that probably have the highest burden of a given disease, but are often underrepresented in studies. And so by being able to look at them individually, even if the aggregated data didn't do subset analyses, we find helpful. Thank you. We can talk more at tea.
I think there was a question back there. Yeah, back there. And
Thank you very much. My name is Robert from Ghana. And I must say those are very interesting presentations. Apologies if my question is also directed to the presenter on data sharing, because I thought that was quite thought-provoking. My question to you is, how do we unbridle this whole issue of power play between funders and then research scientists? Because oftentimes the funder comes with the agenda already set, and then you, the researcher, more or less, you don't have a bigger muscle. So you are collecting the data on the field and it's already landing somewhere in a server. Where is the sharing protocol? What would be your, suggestions and maybe some few recommendations, particularly for those of us who are early and then mid-career researchers? Thank you very much.
Great question. I hope the next question is for someone else. I think that it's really, really important. And I think that's why I put so much emphasis on a repository that curates data and it's ready to reuse. In the start of our work, it would often take 1 or 2 years to collate and curate all the data in a way where we could do a secondary analysis. But once that's done, all we want is for someone like you to come and say, in Ghana, we're really worried about artesunate amodiaquin doing something strange to safety. And we have this question. I've spoken to my friends in West and East Africa. They have the same question. I want to see if there's enough data out there that can answer my question. So it's up to us as a community to pose questions. TDR has a data access committee. They'll say this is very credible use of that data. It's compliant with what we meant to be doing. And the nice thing about once the data is in the repository, there's no funder in control of the agenda of what the data gets used for. And the more it gets used, the more questions we answer, the better off we all are. Thank you.
Just quickly to add to that, as a funder, I feel like funders are getting a bad rap here today. And just to say that, I guess we do have our sort of strategies and agendas to a certain extent, but I would like to think that increasingly we are sort of open and are listening to what countries want and what countries need. Because what we want as funders is to make impact, right? And you guys know better than we do what's needed to make impact. So yeah, hopefully that's sort of coming across a lot more in the interactions and discussions that we have with you guys. So on to the next questions. Hopefully Karen is going to get a bit of a break.
I have one question here. So I'm sorry, this is also regarding data sharing. I had plenty of questions for the data resharing part, but let me just move to the most important one, which is you mentioned the data being anonymized completely. So my question is, like, if the data is truly anonymized as per GDPR, what can you comment on the usefulness of the data and what covariates are lost and how can people use that data once it's truly anonymized?
Sorry, we didn't hear the question properly. Do you mind coming closer to the front?
Yeah, so my question was about data anonymization. So the question is, like, if the data is truly anonymized as per GDPR, which is a very vague definition, but then, people cut out certain covariates, you take the end of the tail and so on. So my question is, like, how useful is the data once it's completely anonymized as per GDPR for secondary analysis, pooling, IPD between studies? Thank you.
Thank you so much for that question, because it reminds me what I didn't say and what I should have said is the most important aspect of a data repository like ours is that the data is linked. So we can see that this person who had a treatment failure had these mutations in their parasites and had a normal drug concentration. So it wasn't in underdosing or unusual pharmacokinetics. By linking all of those things, that's when the data is useful. And we do the same thing. We see that some adverse events are more common in young children. We can see higher treatment failure in people who are wasted, but not in children who are stunted. So I should have emphasized these guys at the front with minutes looking at you make you rush. I should have emphasized the importance of the linked data.
Right. So time for 2 more questions, I think. So in front and then back. Okay, 3 more questions.
Thanks to everyone. My name is Yoba Saidu. I work for the Clinton Health Access Initiative. Unfortunately, my question is not about data sharing, so I think you can relax. My question is actually directed to Thomas. Thanks for the exciting and insightful presentation. I think EDCTP has kind of accomplished a lot based on what we have said, and perhaps one of the key things that led to this great achievement is the involvement of researchers and PIs from Africa taking the lead. But you kind of mentioned something that is very disturbing, indicating that there are some sort of legal concerns that particularly countries that do not have science and technology agreement with the EU cannot lead those in short projects funded by the EU. So I think for me it's a little bit concerning because that can affect motivation and so on. And the question is, what can we do as researchers, as maybe advocates to actually facilitate this sort of legal agreements? I know I have done research, and I know researchers are really not very good at getting governments sign legal agreements. But I know other people like development partners are very good at that time, at actually getting government to enter into agreements. We have seen that with Global Fund, United, and maybe Gavi. At least getting governments to enter into agreement, pay co-financing, and subsequently sustain the investment. So is there anything we can learn? Can we take that angle to actually get our governments to enter into those agreements, facilitate? Can we leverage the know-how of development partners to get this thing in place? Because it's a very important aspect. Over.
No, thanks very much. I think that's a very difficult question to answer in 1 minute. So I think we can take that offline to see what you can do to help your country to overcome those hurdles. I really understand that getting science and technology agreement between states and unions is not a one-day thing. And I'm sure most countries that don't have the agreement have pondered over it before and weighed the advantages and disadvantages and took their priorities. But we are on the receiving end. And I think this can be done, can be solved in different ways. But advocacy, like what you're doing now, is also very important, because if it goes into the reports of the conference that conference participants were concerned with such kind of arrangement, then it starts to make, some people start to hear. Yeah, but we can take it offline and then we can work together on that.
Really sorry, but we don't have time for any more questions. But feel free to catch any of the panel members during the break we have next. But I'm going to ask you guys really quickly, because otherwise Trudy's never going to invite me to chair ever again. So 20 seconds. What's the sort of one key takeaway you'd want the audience to take from what you presented today?
Yeah, so for me, I think it's quite clear that networks and collaborations are a way to go. And but we also need to look at the local context, the ownership and leadership of the sites and the countries is also very important, because just copying and pasting is not a wise idea.
I've probably already said more than enough, but I want to emphasize the power of us working together wherever we choose to network as much as possible in the places that benefit the communities the most, and for funders to keep making that possible. Thank you.
I think the network is the most important part of every research setting, and we all can learn from each other, and that we can solve particular problems as a team is the most important part.
I would like to say that building trust is a multi ways because we had to build trust across departments within one hospital and then across institutions in Honduras, and then 2 ways from Honduras to the international collaborators and from them to us.
Okay, my take-home message is that we need one health approach, and we have to unite as a world to fight antimicrobial resistance. Otherwise, we are going to perish very soon. So let's unite, fight the way we fought HIV, the way we fought COVID. Another problem is antimicrobial resistance. Veterinarians, health, medical people, farmers, everybody, please rise up, spread the gospel.
Yeah, I think all that's left for me is to say thank you very much to the panel.
Thank you.